Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
We're very excited now to have someone who does so much good for so many people. Somebody you wouldn't really know what they do, but Dr. Ahmed Osman is an electrophysiologist, which is a big, long word anyway. And he, of course, was great at our last Cure Symposium. And, of course, when people ask you what you do and you say that, of course, you really did start out as a cardiologist, though.
Yes, good morning, Anita. So, yes, electrophysiology is a specialty within cardiology. So you have to be a cardiologist first and make sure you understand how to manage and treat all sorts of cardiovascular problems. And then if you are interested enough to pursue a little bit more specialization, then what you do is you can choose from several subspecialties. And one of them is cardiac electrophysiology. This is a subspecialty that really takes a closer look at rhythm problems, abnormalities of the heart rhythm, the heartbeat, as well as whether it's slow heart rates, fast heart rates, and benign ones, not so benign ones, and dangerous ones, potentially life-threatening rhythms. And we have a lot of tools in our
Toolbox.
in the box to really manage and treat and in many cases cure some of these abnormalities and have our patients live healthier lives and with elimination of symptoms in many cases.
And the new word is so funny. It's like people will say, well, I have, there are all sorts of terms for things, but now they say I have AFib. AFib. Okay, what is that? Something you eat or something you drink? No, it's something else. And so do you say to people, how do you tell them that they have AFib and what is the real word?
Yeah, so you've heard it being, said that way. And it's really a very common rhythm abnormality. As a matter of fact, it is the most common rhythm problem that I treat and deal with in adult electrophysiology, cardiac electrophysiology. It's the name or the short name for atrial fibrillation, which really, unfortunately, affects 1 in 4 of us in their lifetime. So it's a very, very common rhythm problem. It has to do with a very abnormal, chaotic type of rhythm from the top chambers of the heart. So that's why it's called atrial. It comes from the atria, upper chambers of the heart. And instead of having the normal, regular heartbeat that is really initiated by the normal pacemaker of the heart, you have a very irregular, and that's how we typically describe this rhythm. It's a very chaotic, all over the place type of rhythm. It's usually a little bit on the faster side. And many patients with atrial fibrillation are very symptomatic with it.
And so, it's funny. A lot of people have no idea that there's a rhythm in the heart. The heart beats, beat, 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 right? But you, of course, now as an electrophysiologist, the first thing you want to know is that heartbeat working correctly? And if it's not, there's a way, of course, maybe years ago, you probably had to get into the heart and you had to open up the chest. And now you do it differently, don't you?
Absolutely. Well, I always say that it's fascinating how the heart rate is regulated. It really is a millivolt level electrical impulse that is generated by specific and special cells in the in the upper chambers in the right atrium, and then that little cardiac electrical impulse basically travels down through the upper chambers, down to the bottom chambers or the ventricles, which is the main pumping, area of the heart. And it's very nicely regulated, from the brain down, according to the overall body's needs. And it's a very fine-tuned balance. There is, there is a lot of autonomic or involuntary control of the heart rate that comes directly from the brain. So when that kind of goes berserk, then that's when we end up with rhythms like atrial fibrillation. And yes, you are right. We had, I always say that for atrial fibrillation, because as chaotic as it is, it really had no specific interventions to try to eliminate it before 1998. So we really knew very little about it before that time, and we were used to administer and prescribe medications to control the heart rates and to prevent blood clotting, which is a very, very important area that
Did
I'm
it
sure
work
we will touch.
before?
Not at all. It really left the disease to its natural history, and it let it just progress with time to become more and more entrenched and more stubborn. And so typically this atrial fibrillation rhythm problem starts very sporadically. So we call it paroxysmal. So there's 3 P's that I'm going to mention in atrial fibrillation. The first phase is a paroxysmal phase, where it's really very brief episodes. It lasts anywhere from a few seconds to a few minutes. And
What is it? What is the
just
episode?
episodes of the symptoms of atrial fibrillation that you would get, which are really feeling the heart racing, palpitations, shortness of breath, heart irregularity. Sometimes patients feel dizzy or lightheaded. And all of these symptoms are the typical or classic symptoms of atrial fibrillation. This is and early on it's paroxysmal, meaning that it comes and goes on its own. So it stops after a few minutes, and patients really feel the immediate relief once it stops. And so that's how it starts. It becomes more and more persistent and more progressive and more long lasting. And that's when we move on to a more persistent phase, where it really starts, and then the doctors or the healthcare providers have to do something to stop it, typically lasting up to a couple of days or so. And that's when we talk about what's called the cardioversion, which is a very simple resetting of the heart rhythm that has to be conducted in a healthcare facility.
And you actually can reset the heart rhythm.
So yeah,
Is
that is
amazing?
Absolutely. So basically what you do is, it's called the cardioversion, which many of your listeners may have heard of, but that's a very, very quick delivery of electrical energy across the chest. It's a shock, basically, that's given in a very controlled environment to simply just shut those abnormal firings that cause the atrial fibrillation and let the normal pacemaker resume its usual function and restore what we call a normal sinus rhythm, which is the normal heartbeat of the heart.
And when do you put a pacemaker in? I mean,
So-
do you always have to, or can you just reset it and it's okay?
Very, very common question. So pacemakers really are designed to prevent slow heart rates. And not every patient with atrial fibrillation has slow heart rates that would require or benefit from a pacemaker. So pacemakers are really left for patients who have also weakness and disease of the sinus node, which is that normal pacemaker of the heart, in the sense that it really, when it beats, it's beating at a very slow heart rate, and it's causing symptoms of what we call bradycardia. So bradycardia is the fancy word for slow heart rates. And that's the only time we talk about pacemakers. So some patients require pacemakers, some patients don't. So it's very dependent on the specific situation.
And I've been with you enough times and heard enough that I want to get into the pacemaker world, because years ago, and I don't know, you said 1990 something, that you didn't even have you weren't dealing with AFib, but pacemakers were large, weren't they?
They
you had
were-
to put this big thing in somebody.
Not only were they large, but when pacemakers were first developed, they were outside the chest. So you had a wire that would connect to the outside of the heart through the chest, and basically you can guess how much of an infection risk that is, and all sorts of complications and problems. But yes, this has evolved tremendously, and with the miniaturization, with the technologies that have really evolved tremendously in pacemaker the technology and science, we are really now we have at our disposal a very, very, very sophisticated range of pacemakers and defibrillators, which is a further phase from in cardiac device therapy. That and these devices have become very smart, very reliable, and very sophisticated.
Small.
And very small.
You talked about
very
that.
Small, absolutely. So
So,
that's
then, if you were a manufacturer, besides being this famous doctor, but what would you want to be able to create now that isn't there? I mean, I'm sure you've said as doctor, well, if I only had this, I could do that.
Well, I mean, there is ongoing evolution in cardiac device therapy technology, and there is a lot more to desire and to be, eagerly awaiting. And truly, what we will end up having is pacemakers. So if we talk about just the pacemaker part of the science, or the defibrillator part of the science, then we really are looking at leadless systems. And let me tell you what a lead is. So traditionally, pacemakers are just a generator, which has a fancy computer that will fire at a specific and regular rate to maintain a lower heart rate. And that generator is usually implanted under the skin and below the collarbone, and has to be connected to the heart. And traditionally, and for decades, we've used what we call leads, which are very thin wires, basically, that transmit that electrical impulse into the inside of the heart to maintain the heartbeat, to activate the heart specific chamber that we want to pace, and that can be anywhere in the heart. So those leads, which are wires basically, would travel in the veins all the way into the inside of the heart and be submitted to this repetitive mechanical movement of the patient, and the arm movements, and a lot of mechanical stresses. And that's
I'm gonna interrupt you, because as you're talking, I keep having these questions. What are the leads made of?
the leads are made of metal that is basically a conductor. It's literally a wire that is covered or insulated by an insulation material, so that it doesn't come in contact with blood and gets degraded quickly. But no matter how great those leads are, in 5, 10, 15, 20 years, those leads start breaking down. And that's exactly where the weakness of this pacing technology is. And it's been traditionally the Achilles heel for pacemakers. So if we imagine, or we can imagine, pacemakers that are implanted or inserted inside the heart directly without the need of a lead, then we've eliminated a very large portion of the problems, of the complications that we see with leads. Because leads have to be inserted, as I said, through the veins, and that by itself can cause problems such as blockage of the veins, so the arm gets more congested, if you wish, because the vein that serves the arm, it then has a bunch of more wires in it. It creates a problem with infection, because that typically is a portal really to infection going all the way into the heart, and so on and so forth. So we have a whole subspecialty, if you wish, that deals with how to manage all these lead problems with removal, with extraction, which are very dangerous procedures.
Oh my goodness.
And it's just a kind of a service technology, if you wish, which would be completely eliminated if we imagine a world where the pacemakers don't require leads.
And they don't have any yet.
We have one.
Ah.
So that's why I'm very, very optimistic, and I'm very excited about the future of pacing, because in the hopefully near future, we'll see a full pacing system without any leads. Right now, we have a single chamber pacemaker that is leadless, which means it doesn't require, it's like a little pellet that has tiny little hooks.
Yes, you've shown this at our Cure Symposium.
Exactly, and that basically gets positioned inside the heart. It doesn't require leads. You eliminate the problems with leads in that situation.
Still has little metal pieces, as I recall, though. So
it's a little piece, little metal pellet that basically is very smart, and can listen to our orders from outside by using a programmer and adjusting the heart rate, and basically can stay and work very nicely for many years, so up to 10 years, depending on how the patient's requirements are.
And you said it was single, though. So you're saying what happens to the other places that need it?
Exactly. So the indications for single chamber pacing are somewhat limited right now, because most patients that have a normal rhythm or have a normal atrial activation then would benefit from a dual chamber, which is what we put a lot of, which will, it gets inserted a lot, and that's still in the works. So it's not there yet, but stay tuned, because I think we're going to have those very, very soon. And not only that, we also have pacemakers that can help the heart function. So we have pacemakers that would pace not just the bottom right chamber, the right ventricle, which is where typically we go into to pace keep a heartbeat, but also the left ventricle. So that also requires a lead as it is right now. I think we are going to see some different kind of shape of pellet that we can insert, whether from the inside or the outside, to pace the left ventricle. So eliminate completely the leads, the need for leads.
So this is what your hope for
Very
your
exciting
patients
times.
aren't you?
Absolutely.
And when you think of it, but now, do they come to people like you, physicians who work in this field, and ask you, and share everything they're working on so that you have an input?
We have a lot of input, thankfully, with the industry, if you wish, the cardiac device therapy companies. They want to hear the doctors that are involved in this field, because we certainly would think they should hear our input, because that's really a very valuable part of taking care of patients. I mean, we are really ultimately the ones that are taking care of the patients, and it certainly would be important for them to devise therapies that would be good for the patient, and also user friendly for the physicians, and that would do the job well and safely. So these are very important considerations. Absolutely.
So when someone, is it ever possible that someone has a pacemaker, but then they get better and they can get it removed?
Rarely so, but there are some times, and I would encourage all your listeners to always ask about when somebody or a loved one is told that they need a pacemaker. Is it something that is a definite need, that's more of a permanent problem, or is it a transient problem that somebody saw? Because there's a lot of transient rhythm abnormalities that sometimes I don't want to say hospitals and physicians rush with pacemakers, but there is sometimes some transient rhythm abnormalities that can be watched and perhaps kind of monitored to see if they are really something that's more recurrent and or permanent, that will require a permanent solution. So if it's a transient problem that has some other reason that could be managed, then perhaps we don't have to have a pacemaker. So we don't, there are very few instances where you rush with a pacemaker when it's very clear cut that there is a fixed problem. But in many cases, you really want to give yourself a deep breath and take a look at things another time and decide what's best for the patient, because it's a minor surgery. And the other thing that I want to also, advise your listeners about is to really talk to an electrophysiologist when you are going to require a pacemaker. And the reason I say that, it has become a subspecialty of its own. 40 years ago, surgeons used to implant pacemakers. They were very basic and rudimentary pacemakers. We had so little knowledge about how to implant a pacemaker, where to put the lead that we use today, how to program the pacemaker. And not every pacemaker is the same, and not every way you program a pacemaker is the same. So it's really important to go to someone who would individualize. I mean, I always say these rhythm problems have to be managed very, very, very individually. Every patient is different. Every patient has different requirements, and there are ways and ways and ways of doing this. So
that's very, very, very good advice. And I think at this time I'd like to have a phone number, a way for people to contact you.
Thank you. Yes, so my office number is 954-678-9531. And my practice is called the Florida Heart Rhythm Specialists. So I have been blessed with having several partners who have been truly brothers to me in my practice, and I've been really blessed all along.
And you enjoy working. You enjoy
I do.
Your patients and your colleagues.
Very much. So we've been I've been in Broward County and South Palm Beach County for a good 15 years now. And amongst the five of us, we really are very busy in all of the hospitals in the area. So we literally cover all the hospitals in the county. And,
okay, so I ask always weird questions. I ask the kind of questions that people are afraid to ask, but I'm going to do this with you anyway.
Uh-oh.
No, you know the answers. So when you were going to medical school and you decided you wanted to become a cardiologist, now you aren't a cardiovascular surgeon, you're a cardiologist, right? Big difference. But when did you first get to see a real heartbeat and touch it? I told you I am weird. But everybody...
No, so we during medical training you get exposed to live cardiac surgeries. So you are you have rotations in surgery where you get basically exposed to that. I also happen to have done some cardiac surgery training in my far remote past, so I have been exposed to that as well. And like I was saying, as cardiac device therapy has evolved, we have now really been surgical training has been incorporated in this subspecialty. So all the cardiac electrophysiologists that are going through training right now are taught how to really conduct these surgical procedures in the best way that it needs to be done. So there's a lot of training that goes all along. But open heart is part of cardiac surgery, and we don't really need open heart. So this is the nice thing about modern science and technology and advancements in the field. We do so much without having to really look at the heart, eyes to eyes, because you can do so much more without having a sternotomy or a thoracotomy, which is when you open the chest to really get access to the heart. So there's one area that I want to mention to you that's really very important to your listeners as well, and that's the area when we talk about preventing the main problem with AFib. So I'm going to call it AFib since you endearingly call it so. The AFib problem is really a problem of anticoagulation. And let me tell you what anticoagulation. Anticoagulation is using blood thinners, what we also use, call very endearingly blood thinners. And blood thinners are medications that prevent the clotting or inhibit the clotting mechanism in the body to prevent clots from forming. So clots form very commonly in atrial fibrillation, and every patient has a different kind of risk profile for clotting. It depends on whether you have hypertension, how old you are, whether you've had any strokes before, whether you have heart failure or not, whether you have diabetes or not, whether you have vascular disease or not. And I'm here reciting all the specific risk factors because I use these every time I see a patient with atrial fibrillation to determine what's called their CHADS 2 VASC score. So another tip for your listeners. When you go see a heart doctor and you see an electrophysiologist for your atrial fibrillation, and I encourage you all to go really chat, at least have a chat with an electrophysiologist, okay? Because you don't want to be spending years and years and years not addressing the atrial fibrillation earlier and perhaps giving you much more relief earlier rather than later, because later is really much more difficult to treat. So as soon as you hear that you have atrial fibrillation, say, I'd like to discuss this with an electrophysiologist because there are a lot more advanced therapies that we have that can perhaps help you eliminate the atrial fibrillation for a long period of time. And I'm not saying cure because we are really working on a few things to hopefully help our patients that way, but at least give you relief a lot longer than if you were just left with medications and pills. So let's get that out of the way. Now, anticoagulants. So the one thing that you also want to ask your doctor, what is my risk for a stroke? Because 20% of strokes are caused by atrial fibrillation. And you want, this is a risk factor that you can eliminate completely. And how do we do that? We use anticoagulants, blood thinners. And we have several of them. I'm sure many of your listeners are familiar with Coumadin, which is a very old drug that we've been using a lot for maybe 50 years or so. It's not an easy drug to use. You have to monitor it. You have to get blood tests to check the levels. It goes up and down. As a matter of fact, half the time the patients are not therapeutic, which means that they're either not protected at all or they are at an increased risk of bleeding because the level is too high. So it's a messy drug. And the other thing is, patients are not supposed to eat too many greens. So green leafy vegetables, which we'd love to have everybody eat, are eliminated in that population and really is a very difficult drug to use. So there are newer drugs that we have that are easier to use, that are anticoagulants, luckily. but they are anticoagulants. And about 20 to 30% of patients that started one of those novel agents, and I'm going to mention the names just like Pradaxa, Eliquis, Xarelto, Savesa, there's 4 on the market right now. Those are at risk for bleeding if they injure themselves, and 20 to 30% of those patients will stop those drugs because of one problem or the other. So we luckily have a non-surgical way, and I'm coming back to why technology has really advanced so much, a non-surgical way of eliminating the risk of a stroke. So you'll tell me why. I mean, you're taking a pill. How are you going to do surgery and eliminate that risk? Well, the answer is clots that form in atrial fibrillation form most commonly, the vast majority of them come from a small area in the upper chamber, left upper chamber, the left atrium. It's called the left atrial appendage. And that left atrial appendage is really a pouch that, because of that structural kind of formation, allows blood to stagnate and clots to form. And if those clots form and then break off, then they can cause that stroke. So the strokes in atrial fibrillation, more than 90% of the times, come from little clots in the left atrial appendage. So what can we do about it? We certainly can do a lot. Now, traditionally or many years ago, all that you could do was really, if you were having an open heart surgery or if you had really major problems, then a surgeon would open your chest, whether it's a small incision, it's a big incision, it's an incision into the chest, into the heart sac, and amputate or exclude or clip the left atrial appendage, which means that that pouch is already excluded and there's no chance of clots forming in it, and it's not able to have any clots break off and cause a stroke. We can do that now without open heart, without open chest, which is really a blessing for many, many, many of our patients. And we've been lucky to have this technology available in Broward County for our patients for several years now. We've been really leading this type of procedure. It's called left atrial appendage occlusion, LAAO. And really, we have several options. We have several devices. The one that is currently available and approved by the FDA is called the Watchman device, and it's a 30 to 45 minutes procedure, and it's a one-time procedure that eliminates the need for lifelong use of blood thinners. Who needs that?
I just love this. Every time you come on, it's like I sit here with my mouth open all the time and get the flies in there. Dr. Ahmed Osman, O-S-M-A-N, and let me give you a phone number. Everybody ought to really think about what was said here on the show today, and I now have the person that you want to go to, and the phone number to call for an appointment is 954-678-9531, and the name of his practice is Florida Heart
Rhythm.
I'm sorry, I didn't get that word right. Rhythm specialists. Okay. Dr. Osman, it's always such a pleasure. I know you have a busy schedule and you came here so early on Saturday morning, but I appreciate you so much.